Hello, and a very good afternoon to all. To mark the World IVF Day, that is in vitro fertilization, on July 25th, we are here with a new episode of the Hindu Wellness webinar on myths and facts of IVF. The session is presented by Prashanth Hospitals, Chennai, and we have a powerful all women panel of highly qualified doctors to discuss IVF, which, as we know, is a form of assisted reproductive technology, and it is often used when other fertility techniques perhaps fail. The IVF procedure helps couples conceive a baby by combining an egg and sperm in the laboratory to create an embryo, which is then translated to the uterus. So, without wasting time, because it's a big panel, let me straight away invite our first speaker, Dr. Lakshmi Srinivasan, Senior Consultant Obstetrics, Gynecology, and Infertility at the Vellacheri branch of Prashanth Hospitals, to introduce the topic. Dr. Lakshmi has 20 years of experience in assisted reproductive technology, which is also known as ART in short form, and she has pioneered success in several challenging cases. After completing her MBBS, she did her DNB and DGO, followed by MRCOG from London and advanced diploma in reproductive medicine from Germany. She has also been a part of the teaching faculty. So it's over to you, Dr. Lakshmi, for your presentation on ethical and cultural aspects of IVF.
Thank you, Soma Basu, for the glorious introduction. I'm happy to be here on behalf of Prashanth Hospitals to discuss about IVF, the cultural and ethical aspects in India. Before I go into my topic, I would like to give a brief introduction about IVF and then go into my topic. Now, in vitro fertilization, which is popularly known as the IVF, is a type of assisted reproductive technology where the sperm and egg are fertilized outside the human body. Now, IVF is as such a complex process that involves retrieval of eggs from the ovaries and manually combining them with sperm in the lab and for fertilization. Now, after 3 to 5 days of fertilization, the fertilized egg, which we now call as the embryo, is then placed inside the uterus. Now, pregnancy occurs when this embryo implants itself in the uterine wall. So, IVF as such has captured the attention of the public since its sensational introduction in the year 1978 with the birth of the first IVF baby, Louis Brown. Now, in the 4 decades following the birth of Louis Brown, innovations in ART have overcome numerous unsurmountable barriers to allow couples to have a chance to have a family. Now, in the first decade, significant development as such led to greater efficiency, basically to improve the success rates of IVF, and later expanded accessibility of IVF to the general public. Now, initially, IVF was offered to women with blocked fallopian tubes or problems with egg formation. Now, later in the second decade, innovations, refinements in technology led to the introduction of what we call as a ICSI or ITSI, which is intracytoplasmic injection of a single sperm into an egg. As you see in the picture, in IVF, a host of sperms are placed surrounding the egg and it's allowed to fertilize. Whereas in ITSI, a single sperm is directly injected into the egg. So this is basically used for men with very low sperm counts or even complete absence of sperms in the ejaculate by using special techniques to retrieve the sperms from the testes. So this was a great breakthrough in male infertility and IVF per se. In the following years, of course, egg freezing and sperm freezing, which was already prevailing, actually provided hope and options for women and men undergoing radiation treatment or chemo treatment for cancer cure, which otherwise would have rendered them infertile. Now, more recently, the advances like PGT, what we call, that is the pre-implantation genetic testing, where the embryo formed by ITSI in the lab is tested for chromosomal or genetic abnormalities, and the genetically selected normal embryo is then transferred to the womb. Now, this provided couples with certain sex-linked genetic problems or other genetic disorders the ability to have children free of this condition. Now, in India, if you see the overall demographic population, though it comprises almost 65% of people are young, that is lesser than 35, still infertility is a bigger challenge than we actually perceive. The fertility rates have steadily gone down. that the rising prevalence of late parenthood has increased the incidence of fertility due to declining egg quality among women, and sedentary lifestyle has added on to it. Despite more than 4 decades, as I said, of IVF, multiple milestones in IVF being achieved, and more than 10 million babies have been born through IVF, yet infertility remains a social taboo, and IVF still a contentious, debatable issue. Now, ART, while giving hope to millions of couples suffering from infertility, this has also presented new ethical, legal, social dilemmas, and this the society must address. Now, we hope the various topics to be discussed today would actually debunk all these myths related to IVF from a broader perspective. Now, if you could see the religious perspective of IVF, dating back to ancient eras, there's a lot of reference in Hindu mythology about cloning or test tube babies. Now, there are examples in Mahabharata about artificial insemination, about Bhagavad Puranam, about surrogacy. It shows that olden day sages basically understood the problem of infertile couples and justified treatment outside the natural means of conception. If you take Islam, Quran as such says two things. That is, the progeny and wellness are the two main adornments in Quran. Now, when procreation fails naturally, seeking infertility care is not only permissible in Islam, but also encouraged because adoption is not an acceptable solution for them. Now, in Islamic law, all technologies are allowed, provided that the source of the egg or sperm comes from the married couple during the span of the marriage. The freezing of embryos, transfer of embryos at a later date does not infringe any Islamic law. But however, no third party should intrude the procreation. That is, they do not allow surrogacy or donor gametes. In Christianity, if you say, right when IVF was born, that is in 1978, the doctrine first emerged as Donum Vitae in 1987. It said yes to life and a complete no to IVF. It basically argues that IVF fails to respect the connection between the conjugal act and procreation and deems it morally unacceptable. Now, the revised Dignitas Personae came in 2008, and from the bioethic perspective, the human embryo, they said, has to be treated with the dignity of a person and as such needs to be respected. The document critical stands against IVF or any embryo preservation or any other handling of embryos in the lab. Now, between the various groups of Christianity, however, practices may differ. The Vatican Catholics completely are against IVF and embryo transfers or embryo freezing. The Eastern Orthodox people, they allow medical and surgical treatments, but they're against IVF, whereas the Protestants, they accept all forms of IVF treatment, but do not accept donor gametes. Now, overall, in a religious perspective, it is very imperative to consult your religious advisors, the IVF specialists, to understand your specific perspective, your clinical issues related to your fertility, and to see IVF as a medical treatment rather than violation of your religious convictions. Now, if you see the socio-cultural aspects of IVF, now the cultural ideologies actually shape the demand for IVF in India, if you take. The need to bear a child or to undergo fertility treatment may be basically to revoke a sense of defemininity, guilt, shame, embarrassment, or any other negative feeling in a woman. And it may actually be intensified by the familial and social pressures. Now, it is basically ambiguous whether this infertility is a biological problem or a social problem. Therefore, sometimes what it mandates is what we call as mandate treatment by proxy. That is, the couple do not want it, but the society wants it. Now, male infertility is often also surrounded by a cultural taboo and contribute to silencing and stigmatizing. Now, according to Indian traditions, producing an offspring is often considered as an earthly duty for them, and failure to do so may lead to social anarchy. Now, however, whatever we do in the IVF lab, be it a simple procedure like artificial insemination of the sperm into the womb, or IVF, or manipulation, these have greatly changed that what was once considered a kind of province of two people who were joined by a socially approved union. Since as IVF fundamentally challenges these deep-rooted, held moral, ethical, religious values over what happens naturally, not only the couple, the child born out of it, and of course the IVF treatment, all comes with a taboo. So overall, for this social cultural factors, it is very vital to consider infertility and its treatment as such as a medical condition akin to any other medical condition, and to break the social taboo, we seek support, encourage open discussions about reproductive health in the family, the community, and with the professionals. Now, considering the ethical decisions in IVF. Now, there could be potential harm when we transfer more than one embryo in IVF. So this can result in multifetal pregnancies for the mother and the fetus. Hence, it is imperative to transfer single embryos in favorable situations. Now, what we call is a high-risk women, that is, women of advanced maternal age or any pre-existing medical problems. Now, they do not fall under the same category as the low-risk women. So they have to be evaluated prior by a team, and clearance for ART must be obtained before starting the treatment. And patient should be made aware that she's at a higher risk than the others, and she has to be made an informed choice having understood the risk and benefits pertaining to her. The other ethical dilemma is need to determine when ART can be safely offered to women of advanced age and when it should be denied, considering the safety of the age of the parent and the child's future. The maternal neonatal problems, as we know, are significantly higher, and deaths are also significantly higher at advanced maternal age. So the guideline and bill suggest an upper limit of 50 for women and 55 for men for offering IVF treatments. About social freezing. Now, social freezing may give women the flexibility to preserve their fertility potential while postponing the childbearing to a later age. But on the flip side, what it does, it may potentially increase the risk to the mother and the baby to a high-risk pregnancy at an advanced age. So the other ethical dilemma about stored gametes is what happens, who owns the stored gamete once there is a separation of a couple or a demise of a partner. And there comes the ethical dilemma when disposing the excess embryos as well. Now, PGT, which we already told about, genetic testing, and sometimes may be used for sex selection for a health benefit, that is choosing the embryos which are normal so that the sex-related disorder ones are not transferred and the normal ones are transferred. But however, when sex selection is done purely for the preference of the parents, it could, done on a large scale, skew the general population. So there comes the ethical dilemma. One more ethical concern is the possibility in the near future where technology may permit the manipulation of genetic material within an embryo and what is to be created to call, what we call it as a designer babies. Next comes the ethical problems of commercialization of IVF. Financial burden to the couple is also an ethical dilemma, which the subsequent speakers would be throwing light upon. And a touch on the legal aspect. Now, to govern all this, we have the Indian Council of Medical Research, which gives strict guidelines in regulating IVF clinics, and they cover the aspects like confidentiality, consent, and mandating counseling for these couples who are seeking IVF. And the recent ART bill, as such, also regulates IVF clinics across the country. So to sum it all, I would say, balancing the rights and the interests of all the parties involved is the key to harnessing the full potential of IVF while upholding the ethical standards. Thank you.
Thank you, Dr. Lakshmi, for that very comprehensive talk. We now move on to Dr. Samhita Moturi, consultant in obstetrics, gynecology, and infertility. She's also the director of Prashanth Hospitals in Chennai, who, after completing her MBBS and MS in obstetrics and gynecology, did 2 fellowship programs in minimally invasive laparoscopic surgeries and in cosmetic gynecology. Dr. Samhita's areas of interest include infertility, laparoscopic surgeries, and women wellness. And she will now talk on health and safety aspects of infertility. Welcome, Dr. Samhita.
Hello, thank you so much, and a very good afternoon to one and all present here. Thank you so much for the opportunity. So let me just go ahead and share my slides. Yes. So as this webinar is focused on myths and facts surrounding IVF, I would actually like to shed some light on common misconceptions surrounding the health and safety of the mother in IVF pregnancies. So when compared to normal pregnancies where women conceive naturally, the IVF pregnancies do require additional support in the form of hormones and other medicines. But these hormones, which we give, mimic the endogenous hormones or the hormones already present in the women. in natural states. So these medicines do not have any long-lasting impact on the maternal health. So another common concern for a lot of couples undergoing IVF is the effects of IVF on the baby's health. First, let's talk about the IQ, where a lot of parents come to me in the OPD and ask me, is the IQ affected by any chance? But let me tell you that it is totally dependent on the parents, because we take the egg from the mother and the sperm from the father and we fertilize and make an embryo in the lab, and it's completely their own, as you see in natural pregnancies. And another common misconception is IVF leads to increasing birth defects. As my colleague Dr. Lakshmi had already very beautifully spoke about pre-implantation genetic testing, it is a very important tool where we can isolate unhealthy embryos from the healthy embryos, especially in couples who are already suffering from rare genetic disorders and other birth defects and anomalies. This is a boon, and this actually helps in selecting healthy embryos. And these healthy embryos are then transferred into the mother, giving result to a healthy baby. Moving on, let's speak about multiple pregnancy. Definite twin pregnancy from an IVF is a must, is a thing of the past. As we already spoke about, due to the advancements in science and increase in success rates of IVF due to novel strategies, which will be highlighted by the later speakers, single embryo transfer is actually recommended. So what the single embryo transfer does is it results in single pregnancies, singleton pregnancies, which have lesser side effects and lesser complications for the mother, and they also reduce the financial burden on the parents. Another deterrent for all the women planning to undergo or who were suggested IVF is the pain. It's a major deterrent, as IVF actually involves a lot of commitment in the form of regular checkups, regular ultrasounds, and regular gonadotropin or hormone injections and procedures involving anesthesia. So here, let me tell you that all of these are well tolerated, and these gonadotropin injections, the latest ones, are designed in such a way that they cause the least bit of discomfort, and most of our patients tolerate it really well. As far as procedures under anesthesia, such as oocyte retrieval or egg collection, which is compulsorily done under anesthesia, is concerned, yes, it does carry a minimal risk as compared to all the other surgeries and procedures people undergo when they have to. But let me tell you that it's a daycare procedure. It has very less downtime, and patients tend to recover really well. Most of my patients are well enough to just leave the hospital, and they will be discharged by the end of the same day. And I also would like to speak about this is ovarian hyperstimulation syndrome, which is the most important clinical complication that we see in a lot of IVF centers. When I speak about this, we believe that a stimulation protocol, which is tailor-made to that woman based on her checkup, her ultrasound reports, her blood reports of AMH, we can prevent it. And in the hands of an expert, ovarian hyperstimulation syndrome risk is very, very minimal right now. And cancer due to IVF, yes, a lot of patients have asked me this question. Injudicious and hyperstimulation does lead to ovarian cancer, according to some studies, but then again, there is a limit. As per the guidelines, the maximum number of ovulation induction which is allowed is 6 cycles. And let me tell you, this is not the only solution we have for these couples. In case of ovarian induction failure, we do have a lot of other options to take care of the other factors such as tubal factors or uterine causes in the form of hysterolaparoscopy, which is another clinical procedure. So we avoid hyperstimulation, and this can be prevented. So we at Prashanth, we recommend a complete health workup for the mother before embarking on this journey of IVF, because it is paramount and we need to make sure the safety of the mother is the most important thing. Thank you.
Thank you, Dr. Samhita. Our next speaker, Dr. Aparajita V, is consultant in obstetrics, gynecology, and infertility at the Kolathur branch of Prashanth Hospitals. She's an MBBS, MS, DNB, ONG with a fellowship in reproductive medicine from Germany. A fertility specialist, Dr. Aparajita's areas of interest are adenomyosis and poor ovarian reserve. She is recipient of multiple Best Paper awards and has been published in international journals. Dr. Aparajita will now speak on the cost of IVF and why is it a financial burden. Welcome, Doctor.
Hello, everyone. Thank you so much. And thanks for the opportunity. One sec. Sure. So, we as a fertility specialist have the privilege of helping couples achieving their dream of parenthood. But one of the most significant challenges we face is the financial burden in IVF. As we all know, IVF is a groundbreaking medical advancement that offers hope to those struggling with infertility. Among all the fertility treatments available, IVF is the most common and effective ART procedure with about 60 to 70% success rate. But one thing is the cost of an IVF procedure can vary widely, and we can't tell a fixed cost for the patients. So in India, generally the average cost of a single cycle of an IVF ranges from about 1 lakh to 2.5 lakhs, and this is for a single cycle. So many times couples conceive in single cycle and they may require 2 or 3 cycles to conceive. So adding up the cost. And apart from this, it also depends upon the patient profile. For example, if you see a female partner who is above 35 years, who is obese, BMI is more than 30, they may require additional medication. So it differs from patient to patient. Likewise, in male, if you find sperm abnormalities, so your treatment may change. We will have to use advanced technologies, which will add up your cost. So IVF doesn't come with a fixed price tag. It is according to the patient and it is tailor-made. It differs from individual to individual. So why is this IVF costly? Because IVF is not a single step process. It involves multiple stages. So overall increasing the cost of the procedure. So generally it includes multiple consultations with doctor. Patients will have to do a lot of blood tests, ultrasound scans. Sometimes we will have, we have to do husband semen analysis, and sometimes people may require additional genetic testing as well. And the most important part is ovarian stimulation. We give hormonal injections for the female for the egg growth. And once the egg is grown, we take them to a laboratory, to an operation theater. We collect the eggs and the sperms are directly injected into the egg in a petri dish in the lab. That's where the embryos are formed. And sometimes we freeze the embryos and transfer it to them later. And in certain couples, like Dr. Samhita said, people who are having genetic disorders, we will have to do some testings on the embryo, which will be adding your cost of IVF. So why understanding the overall cost of IVF treatment is important? It is because for many families, these costs are overwhelming. And very important thing is health insurance do not cover infertility treatments like any other diseases. So the patients have to pay out of their own pockets. In recent days, certain health insurance companies have come up in tie-up with the corporates, but they only offer for a couple of IUI or a couple of cycles. They don't offer you the full insurance coverage. And one more thing is they have a waiting period of about 24 months of 8 months as such. So patients can't wait so long for their treatment. So it becomes a big financial burden. They can't wait for the insurance to cover. So they come and pay out of their own pocket. So this financial strain can force the families to make difficult choices, depleting their savings, and sometimes even foregoing the treatment altogether. So there are some few tips for them to manage the cost. So we generally tell the patients, nowadays, women are more career oriented and they want to postpone the pregnancy. So we generally advise them to have a pre-conception counseling and decide who will require treatments, who will not require. They can postpone and come back safe and all. So if you are planning for fertility treatments, you have to set aside some amount which will be useful for you. And another one important thing is you have to meet multiple fertility specialists to discuss what are the options available and to understand how much amount will be spent for each procedures. And you should have an informed decision considering all the options so that you can choose an economic and effective treatment plan for you. And very important thing is to research the hospital, fertility clinics. Before you go, you have to choose a hospital with a very high success rate, because choosing a hospital with a good success rate, you can reduce the number of treatment cycles and can conceive in a 1 or 2 cycle itself, so that overall reducing your cost. And sometimes certain fertility hospitals offer you discounts when you go for multiple cycle or during some festive offers, or some may also give you zero cost EMIs. So you have to look into certain strategies, what all is available in the fertility hospitals before choosing the hospital. And there are some support groups like NGOs who fund for fertility, but in India, as such groups are very less compared to the other countries. So, while the financial burden of IVF poses you a significant challenge, we have resources and strategies available to help manage the cost by staying informed. You have to discuss with your doctor what are the procedures is going to benefit you, what are the costs, and take an informed decision. And we have to advocate for better insurance coverages. In fact, in certain states in India, they have started forcing the insurance companies to give full coverage for the fertility treatments, because the incidence of fertility is coming up so much in India. And you have to seek financial assistance and explore all the options available in the fertility clinics, so that we can work together and achieve your dream of having a family at an affordable rate. Thank you.
Thank you, Dr. Parajita, for explaining the cost factor so well. Our final panelist for today's webinar is Dr. Geeta Haripriya, the chairperson of Prashanth Group of Hospitals in Chennai, who also heads the Department of Obstetrics, Gynecology, and Infertility. A practicing IVF specialist with more than 4 decades of experience, Dr. Geeta is a recipient of several prestigious awards, including the Lifetime Achievement Award presented by the GOAL Committee, GOAL Committee, in collaboration with Harvard University, USA in 2010, the Rose of Paracelsus Award from the European Medical Association, Belgium, as a recognition for the best medical practices and practitioner. She has also received the Best Performing Doctor Award from the Government of Tamil Nadu for meritorious service in the field of medicine, and the Best Doctor Award by Dr. MGR Medical University. There are quite a few more which I'm not reading out. A fellow of the Royal College of Obstetricians and Gynecologists, she has presented many papers in national and international journals and conducted conferences. So over the next 10 minutes, you will hear her talk on the novel strategies for increasing pregnancy rates. A very warm welcome to you, Dr. Geeta.
Good afternoon, everybody. I think we had a good overview of IVF and all the good and the bad things associated with it. Not bad, the difficult things associated with it. But what is most important in IVF, what a patient wants, is to become successful the first time that she does the treatment. So we are now looking at novel strategies in IVF, which actually help a patient to get pregnant in the first cycle of treatment. So the first thing in IVF, we need a good egg, we need a good sperm, we need to create a good embryo, and we have to put the embryo in a uterus which is very receptive, and also follow up the pregnancy and support the pregnancy to make sure that you take the baby back home. What is most important is the take-home baby rate, because that is what matters at the end of it. So we try to improve the egg and the sperms by giving something called micronutrients and antioxidants. So these actually have a lot of vitamins. They have a lot of minerals like magnesium, selenium, and a lot of them to actually help the egg and the sperm to in their developmental stage. And a few of the compounds are myoinositol, selenium, N-acetylcysteine, arginine, and polyunsaturated fatty acids, and zinc. Yoga has a major role to play. And when I went to Japan for a training, I found that there were a lot of yoga and acupuncture classes going on. So then I said, how is it going to help in this sort of a medical treatment? But when I came back, I had a group of patients who were really struggling to get good quality eggs and sperms and who couldn't really make it. So I introduced yoga and acupuncture, and I really understood the importance of it. So ever since, for the last 8 years, I've been practicing yoga and acupuncture in the hospital, and there definitely has been a marginal improvement in the quality of the egg, the quality of the sperm, and the quality of the embryo and the success rates. So today we are very concerned about the quality of the egg, and we have a huge number of patients. At least in 10 years ago, I've never seen young patients having such a low reserve of the ovary. But today, this is a real big problem, and we have a lot of young patients, 25, 26 years. They come to the clinic, and you tell them that their eggs are not good, and they are going to stop producing eggs in the near future. So they're totally devastated. They just go to several clinics and get opinions from all of them. And definitely the same thing will be told in all the clinics. And then they come back and they ask, okay, now how do we move forward? So the simple things like diet, exercise, and the yoga, acupuncture are all for people who have a little low quality eggs, and generally for all persons who want to improve their egg quality. But this particular group of patients who have a low egg reserve, so we actually try newer technologies, and this is in the form of platelet-rich plasma. We actually draw the blood and remove the platelets, and this platelet-rich plasma is then injected into the ovary. This we were doing for about a couple of years. Then came in the stem cell therapy, and these stem cells are obtained either from the umbilical cord, from stem cell banks, which have been culturing it for over many years. And the latest is, or, no, I wouldn't say latest, it was there many years ago, but because it was more difficult to aspirate the bone marrow and to get it, so we were doing the umbilical cord stem cells initially. But now we have slowly moved on to bone marrow stem cells, and we have definitely found that there is a improvement in the success rate. So what we do is the first procedure, we like to do it laparoscopically, because you can actually see the ovary and inject the combination of stem cell, platelet-rich plasma, and the growth factors. You can exactly inject it into the space where it is needed and where you will get the best growth of eggs. And to do this, laparoscopy is very important. We use a 3D laparoscopy, which makes it even better because you can visualize everything in a 3-dimensional view, and it really helps us to put it in the right space. So this combination we've been using for about 3 years, and we have found very good success rates. All patients who have been told to go for a donor program, now at least in 50% of patients in the younger age group, we are able to give them pregnancies with their own eggs. And for those over the age of 55, now it's no longer allowed. But if you speak of the less than 40 age group, then you get at least 40% success rate. And when the patients are only 26, 25 years, then the success rate goes up even to 60%. And after we have started using the bone marrow stem cells, the success rate has gone up to 65 to 68%. We can't promise lots of eggs, but we can at least promise 3 or 4 good eggs. And the quality of the egg matters. Even if you get 2 good embryos out of these eggs and you put them in, then it's useful and it's highly successful. We were also talking about single embryo transfers, but in this group of patients, I prefer to put in a couple of embryos because they are in the borderline and we'd like to get a pregnancy in the first cycle itself. Otherwise, a single embryo transfer is what is actually promoted. Now, having done this, the other major issue which we have is the lining of the uterus. So there are some patients with a persistently thin lining of the uterus, which just refuses to accept an embryo. So in these patients, the same combination of bone marrow-derived stem cells and platelet-rich plasma and growth factors is injected hysteroscopically. So hysteroscopy, you actually look inside the uterus through a telescope and you visualize where you are injecting, and you inject it into several spots under the lining of the uterus. The stem cells actually are mother cells. They stimulate the cells around and help it to grow. And this way, the lining develops. We give a month gap, and then the next cycle, we start the treatment, and we use the growth factors and PRP in that cycle as well. And we've been able to achieve pregnancies in at least 67% of these patients who had a thin lining. Sometimes it works the first time, sometimes you need 3 or 4 cycles. But ultimately, if you look at a 6-month period of a trial period, at least 67% of them have conceived. And the miscarriage rate in this group is slightly higher than in normal pregnancies because it's not as efficient as a normal endometrium, but still 67% is a very good value. And the take-home baby rate in this group is around 51%, which is really, really good. Now, this is about the platelet-rich plasma. We use it when the ovaries fail, when the reserve is low, and when the lining is thin. A few pictures to tell you about how we actually take it and separate it and put it inside. Mesenchymal stem cells, you can obtain it from the umbilical cord. There are other sources as well, but bone marrow is the most important one. And the procedure is we actually inject it into the ovary under the first time, I told you it's laparoscopically, but second time, there are patients who don't improve. And we assess that by looking at the antral follicle count, which means you count the number of eggs in the ovaries, and you check a hormone called anti-Mullerian hormone. The normal value is 3. So you want, you may not come up to 3, but this patient would have had an AMH of 0.2. You would definitely, you can bring it up to 0.7 or 0.8, and that would give you about 3-4 eggs. So second time, if they need, you do it under ultrasound guidance. So you put the vaginal probe inside and you inject it, you zoom up the picture, and then you inject it into the right space. So we have now discussed about the egg and the sperm. Now we have to create a good embryo. So artificial intelligence has come in a big way, and you can assess the follicles. That means that there is a tiny little microscopic egg inside a follicle. It's like a small egg in a balloon filled with water. So you look at it in the ultrasound, and the dimensions, the volume, the blood flow, and all this can be correlated to the biochemistry, the body mass index, and other parameters to predict the outcomes in ovarian rejuvenation. So artificial intelligence has really broken the barriers in many fields, including medicine. And even a simple thing like an ultrasound guided, looking at the number of eggs in the ovaries, assessing the blood flow, everything can be done with artificial intelligence. Now, the next thing is enhancing male infertility. So we've spoken about the lady. Now we speak about the man. We also give him a lot of antioxidants. If it is just a low count or even a normal count, to improve the quality, you can give antioxidants, vitamins, and this can be continued for about 2 to 3 months before you start the treatment. Now, hormones are needed in those who have a slightly less count, and you add on many other like L-carnitine. And here it's very important to understand that we do give hormones in the form of tablets or injections. And if everything fails, then and there is no sperm at all, then we have to retrieve the sperms from the testis. So why there are no sperms? There are 3 things. 1, there's no production at all. There is production, but it's too little to come out. Number 3, there is production, but because the passage between the testis and the outside is blocked, then because the passage is blocked, the sperms are not able to come out. So this is something which is very important, because we want to aspirate it as, we don't want it to be invasive. But in these situations, you have to you either aspirate the sperm or you actually take a small biopsy. And micro TC is where the FSH, the hormone levels are so high, then you use micro TC because you want to go inside the testis, and you, with a 40x microscope, which is the most powerful microscope available, you look at the entire testis like this, you see all pouting areas. These are the areas which have the sperms. So we actually take it out and we put it in culture media, we freeze it, and when the lady is ready, we inject the sperm into the egg. Now, how to get the best pregnancy outcomes? We use advanced ART. So what is advanced ART? ICSI means you see sperm 400 times big, and you select the sperm and you put it in an incubator, which is an open system. Daily, you have to take the babies out, check under the microscope for development, and put it back. But if you want the highest results, you use IMSI, where you see sperm 7,000 times big. It's a computer magnified imaging, and you select the top class sperm, inject into the egg, create the baby, and put it into an incubator, which is called the embryoscope, which is designed like the human body. It is a dynamic evaluation and a dynamic, you can actually see the development happening even at 12 hours, 24 hours, 48 hours, 72 hours, and you can see what is happening at each point of time. So this is very important because it actually tells you how the embryo is developing, which are the best embryos to select. It also has an inbuilt camera, so automatic recording goes on. Software analyzes all data. Artificial intelligence gives the baby's marks, and you select the 2 top-ranking embryos. And before putting it inside the uterus, you actually hatch the thick zona in some patients who need it, and you apply embryo glue, which is a sticky substance which helps the baby to stick onto the lining of the uterus. And we use the laser to assist the hatching. And it's like this: you make a small, you thin down the shell, and then you put back the embryos after you thin it in, after you put the embryo glue in. Now, there is a certain group of patients who actually have abnormal babies, repeated IVF failures, repeated IUI failures, and they have a family history of some abnormality, you actually need to select the normal baby before you put it back into the uterus. So you create the embryos, and then you take a biopsy with a laser. You thin down the shell, take the biopsy of a few cells, and then you send it for genetic testing. And this genetic testing actually tells you which embryo is normal. If you have 4 embryos that you give for testing, they may report 2 normal. So only the 2 normal embryos you put back into the uterus. This way, the time to pregnancy, that is the time taken to achieve a normal pregnancy, is less, because you're choosing the right embryo. You're not wasting time putting in the wrong embryos. And the second thing, you are giving them a normal baby. So this is a technique which is very, very useful. And people who have had disasters in the earlier attempts really benefit by this system. This is actually an invasive thing, because you're actually using the laser and you're taking out the cells from the embryo. So today, what has come in is called a non-invasive chromosome screening, NICS. So with this, we actually take the culture medium where the babies have grown, and we subject this to genetic analysis. And there are several studies all over the world which have actually shown that the two are almost similar. That is, the non-invasive system is as good as the taking out the cells from the embryo as a pre-implantation genetic testing. So what we do now in our unit, we have done a study where we have compared both the systems, and we too have found that the system is almost as efficient as the invasive system. And today we're slowly moving on to using the non-invasive technique. Now, how do you make your lab best? You have to put artificial intelligence in all your systems. There is something called an electronic witness system, because patients are very suspicious. The first question they ask me is, not everybody, but at least some of them, is it my sperm, and is it my embryo? So we have something called an electronic witness system, which right from the time that the patient registers, right up to all the tubes where the egg is handled, the sperm is handled, where the embryo is handled, till the embryo transfer, everything is labeled and everything is witnessed, and you know that there are no mistakes in the system. Now, this is very, very important, because you give the patient adequate confidence to tell them that this is their own egg, sperm, and embryo. And this has really boosted the morale of many patients who actually had a lot of suspicion in the system. Now, the next thing is making your lab something called a lab safe system, which means that you have to know whether your lab systems are good. The embryo is a very, very delicate a human being. It's also a human being. So it's a very delicate human being, and it needs only measured amounts of oxygen, carbon dioxide, nitrous oxide, and all other, dust-free, pyrogen-free, clean system. So now this is achieved by using the lab system, because it actually measures the carbon dioxide, oxygen, nitrogen, on temperature, and in all the equipments available in the lab, and makes it, if the assessment is done, it should be 100% perfect system. So this is something which has come in new, and it makes your lab very, very effective and trustworthy. Now we have to put in the embryo at the right time. There are people who have excellent eggs, excellent sperms, excellent embryos, and a good uterus, but still they don't conceive. And this is because they have a particular window of implantation, which actually is very narrow. Normally, window of implantation is between day 18 and day 25. But here the window is very narrow, a few hours. So what we do is we actually find out this particular window by taking a sample of the lining and sending it for genetic testing. The genes are all studied, and then they give you a timing. Now, after you give the progesterone injection, in 144 hours, you should deliver. I mean, you should put the baby inside, or in 120 hours, you should put the baby inside. So if we follow that in the treatment cycle, then it really helps. And the success rates are much better. Now, you have to make your uterus also effective. So hysteroscopy is a condition where you actually go inside the uterus and you solve all these problems. When there are adhesions inside the uterus, when the shape of the uterus is different, that's called a septate uterus. You see a fibroid there, so that can be removed. And there is huge growth there called a polyp, which you can remove. And adhesions means things are stuck to one another, and you remove it to better your pregnancy rates. Now, like I described earlier, 3D laparoscopy is very, very effective. And You can remove fibroids, you can remove adenomyomas, you can drill the ovaries to make in polycystic ovaries. And if there is fluid in the tubes, you can disconnect the tubes. And here you see a picture of drilling the ovaries. So this is used in patients with polycystic ovaries, and it improves the hormone profile and it improves the quality of the egg. And most important, after putting in the embryo, what do you do? Now, for normal patients, we give only hormones, vitamins, and other things. But patients who need a little more, they have problems in their blood called Apla syndrome, and they have a rejection factor. So for them, we give a few drugs like aspirin, the steroids, enterolipids, immunoglobulin, and heparin. So heparin is a blood thinner, which actually keeps the blood in the liquid state all the time. And enterolipid is a substance which actually decreases the natural killer cells in the lining of the uterus. So all these really help to achieve your dream of having a baby, making the take-home baby rate the best that you can. Thank you.
Thank you, Dr. Geeta, for that very fantastic slides and talk. So as one understands, IVF is quite a complicated technical procedure, which involves a lot of emotional drainage and financial drainage as well. So I was just wanting to know, like to undergo the entire process for a couple, I mean, how do you prepare them? What do they need to prepare themselves? Because at the end of it, it could be a happy take home, or it could be in some way, complications and losses can occur, leading to higher financial costs. So do you do any kind of psychological counseling, explaining the procedure? I mean, what does it require for a couple to undergo this IVF process?
Lakshmi, you
Dr.
take.
Geeta? Yeah, Dr. Geeta, maybe you could take that question.
Okay. The first thing is you have to understand their need. The second thing, you assess, you study their health. You study the uterus, you study their general health and all their hormones, and you make sure that they are fit to go through an IVF program. Otherwise, you prepare them and they go through it. Most important is the question that you asked. We give them adequate counseling. Counseling means not just financial counseling. Counseling means you take them through the entire process step by step. Because most important, what patients are worried about is the cost, the time involved, and how long it will take, the whole procedure, how many months it would stretch for. So if you explain to them exactly what you're going to do and answer all these questions, it really helps. And we also tell them that though we plan it effectively, sometimes the eggs may not cooperate, the lining of the uterus may not cooperate. So there may be, you have to stretch the time in a few patients, but it's not in everybody. Maybe in 5 to 10% of patients, we may need to do that. So if you counsel adequately and they're really happy and they go through the procedure, and also you have to counsel them about the success rates. This is not 100% pregnancy. It depends on what your lab offers. It would vary between 65 to 85, 87%, depending upon what sort of problem they have and what they need and the quality of their egg, the sperm, and the uterus. So this is something which is very, very important, because the first question that they will ask you, what sort of pregnancy rate can you offer me, and about the financial implications, and will you give me a comfortable, time in the hospital? So these are the three major questions which people ask.
So the 65% to 87% is the broad success rate of IVF, depending on multiple other factors.
Absolutely. It depends upon the age. It depends on what sort of basic problems they have, and the quality of egg, quality of sperm, and like I described, all the other situations which they can have in their, gynecological history.
Right. Because there's a related question. That's why I asked you. Somebody saying that because all the tests, as you said, are also done. So somebody saying I'm a 2-time IVF failure patient, and both the times the quality of egg, the quality of sperm, and the quality of embryo was reported to be very good. But I got a problem with implantation. My uterus is also perfectly normal. So what can be the reason? So who would like to answer this? Dr. Aparajita or Dr. Samita? You're looking at the health and safety.
Sure. I'd like to take this question. So the implantation failure could be of many causes. But in these thin patients, we do have remedy to it, in the sense that you see this thin endometrium patients quite a lot in our hospital. And what we recommend to them is the PRP procedure and the regeneration procedures, which Dr. Geeta just elaborated about. And that really helps. And it helped a lot of patients achieve clinical pregnancies and live birth rates.
Also,
So I would,
Yeah, please. Yes, ma'am, please go ahead.
Also, you said it is a normal egg, normal sperm, and a normal uterus.
Mm.
So in that case, I explained the ERA to you. It tells you about the implantation window and the exact time to put back the embryo. Many cases where we have seen repetitive failures with no particular reasons, ERA has helped. Number two, you also look at the post-embryo transfer situation. If they have any medical conditions like an Aplar syndrome, or they have a rejection factor, then all the medications which I described, it helps, because there are some disturbances in the blood which cause microclots. Microclots shut off the blood flow to the baby, and therefore the implantation failure happens.
Dr. Aparajita, since you focused on the cost factor and you also quoted a figure, say between 1 lakh to 3 lakhs, so I wanted to know, is that price across the country, or is it only at Prashanth? Somebody wants to know. And what is the status of other similar clinics or hospitals? Because we know Tamil Nadu is generally ahead in many things, but up north or states like Bihar, UP. So what is the status of IVF treatment?
So the cost is approximately 1 to 3 lakh. It is across the country. It's throughout the India. The approximate cost is about 1 to 3. But as I said, it is all tailor-made according to the patient. You can't, none of the hospital in India can give a price tag like we cost only about 1.5, we cost only 1 lakh, because we will charge only 2 lakhs, because each patient has got different problems. One is elderly, one is young, no problems at all. But some patients have husband has problems, sperm problems, genetic problems, a lot of things. So we keep a baseline cost, and we discuss with the patient, we look at the patient, the female wife's profile, husband's profile, and we discuss to them in detail what are the advanced technologies we have to overcome their problems. And finally, relating to their profile, the cost will come.
So
We also give them a detailed counseling regarding the technologies available, and they choose whatever they want accordingly.
And IVF is only available in private sector or the government hospitals also?
There are some states who have started. Goa has started, and in Tamil Nadu recently, last month, they have started. Still, the lab has not started functioning. Tamil Nadu government have started it in Madras Medical College.
And there would be a major price difference? No.
No, they will be doing at they are going to do it. I mean, we are not sure about whether it's completely free of cost or they will charge a minimal cost. They've just opened the lab, and the rest of the things are yet to come.
Okay.
Which will be very useful for other people, people who are not affordable.
So let me bring in Dr. Lakshmi now. You started with the first presentation. So Bhuvna wants to know or wants to have more insights on recurrent pregnancy loss. What are the protocols followed?
Recurrent pregnancy loss as such could be due to various reasons. So infections as a cause may not be a cause for recurrent pregnancy loss. It can cause miscarriage at one time, not recurrence. The other important ones are general being of the mother, like any medical conditions like uncontrolled diabetes. Simple ones like diabetes, if controlled well, can reduce the miscarriage rates. And untreated thyroid, all that need to be addressed before going into fertility aspects as such. The other causes could be related to the uterine factor. We have to rule out what kind of recurrent miscarriage she had. Was it an early pregnancy losses which happened, or in the middle part of the pregnancy? Early pregnancy losses is completely different etiologies, whereas mid-pregnancy losses could be due to factors like, as Dr. Geeta said, there could be a septum or some problem in the uterine anatomy as such, but the cervix being, the mouth of the uterus being weak. This could be a cause. So the cause has to be identified first. As such, the baby being the genetic cause as such is only 1 to 2%. The rest of the things are the ones which has to be identified and treated prior to embarking on a pregnancy. Now, 1 to 2%, as I said, could be a genetic cause in the fetus, which is leading on to recurrent pregnancy loss. Now, this can be assessed by if she has had a miscarriage, was the product sent for any genetic testing. If the genetic testing has detected any abnormality, genetic abnormality or chromosomal abnormality in the fetus, the parents have to be tested for genetic abnormalities. And in those people, when it's found to be abnormal, of course, PGT, as we already said, pre-implantation genetics can help them to choose the right embryo. But more important is all these prior factors, like ruling out diabetes, infections, thyroid, and other things like blood clotting problems, like antiphospholipid antibody, as we said, blood clotting problems, certain autoimmune disorders, all that has to be ruled out as a cause for her recurrent loss. And any correctable factors like uterine factors, all that has to be corrected. And then she has to embark on a pregnancy.
So the same listener is asking, do we need to do PGT for all embryos collected before freezing them?
Okay. See, pre-GT as a as a treatment for recurrent pregnancy loss is not recommended for everyone. As I said, the cause determines what we do. If it is due to diabetes, we don't need to do PGT for them. We have to treat the diabetes and see to it that her HbA1c level is less than 6.5 or at an optimal level at the time of transfer of embryos. But that itself suffices. We don't need. As I said, if a chromosomal abnormality is detected in the baby or a genetic abnormality is detected, only those couple will benefit from doing a PGT or a non-invasive chromosomal screening, not all couples. And it is generally done, as she asked, before freezing. Once the embryo is formed to day 3 or day 5, it is tested, and then the embryos are frozen. We wait for the results. And once the results come back as normal, those tested embryos, which are deemed to be normal, are transferred, so that we can save the couple from, if we collect some 10 eggs and we get some 5 embryos out of it, and it comes back as only 1 embryo is normal, we actually save the couple from going through the 5 pregnancy losses otherwise. So that is the advantage of using it in that particular couple.
So somebody is asking, maybe Dr. Aparajita or Dr. Samita, you could take it, that what is the reason for getting single child through 2 embryos implanted, considering both are first grade embryos?
Okay, so sometimes when we transfer 2 embryos, out of the 2 embryos, we can even achieve a single pregnancy, a twin pregnancy, or no pregnancy at all. So it basically depends upon the implantation rate of the embryos and the uterus factor as well. So it's not that if you transfer 2 embryos, it will definitely end up in twin pregnancy. It can even end up with no pregnancy as well.
Kirti Vijay Kumar, sorry, I don't know this term, that whether teratozoospermia is treatable. Dr. Geeta?
Yeah. So teratozoospermia is when you have more number of abnormal sperms. The normal sperm, as per the WHO, is 4%. And if you have anything less than 4%, that is called teratozoospermia. But in a natural pregnancy, then the sperm which actually reaches the egg first and the healthiest sperm is the one which gives the pregnancy. Now, teratozoospermia needs to be treated. If long time of infertility is there, everything else is good, then you have to treat it. And how do we treat it? We advise lifestyle modification, no smoking, no alcohol, and no coffee. And if they are, under a lot of stress, to avoid stress, obesity, decrease the weight. And you also tell them to have good healthy habits. And if they use, for example, a motorbike, then they're exposed to a lot of heat. So you tell them how to take away, you put a wet towel on the petrol tank, and then you tell them to keep changing that so that the temperature at the testis is lower. So these small modifications help to decrease the abnormal sperms. You also give them a lot of vitamins, like I described earlier, micronutrients and vitamins, and ask them to have a healthy diet, less carbohydrates, a reasonable amount of less fat, and good protein diet, lots of fruits, lots of vegetables, which give a lot of vitamins. So all these, it's a multifaceted thing. You have to describe how to manage it to the patient and tell them all the things that would help to decrease the number of abnormal sperms.
So would the same specific dietary recommendations also work to reduce endometriosis?
Endometriosis is a certain extent only related to food, but it's more important. It is more a genetic problem, and it runs in families. It's more a genetic problem. And there is a saying that, there is a belief that rice eaters have more endometriosis, but it's not definitely proved. So if it is there, then you have to recognize it early and treat it early so that it doesn't spread and cause major disasters.
Dr. Samhita, if you could answer Mahalakshmi's question on how many times can I do ovulation induction without leads to ovarian cancer?
So the ovulation induction, the maximum number of times which is recommended is 6 cycles. But what I would tell my patients is I would probably try 2 or 3 cycles, and we would like to see what other problems and what other factors are leading to infertility in such couples. Because, for example, a lot of couples do have tubal factors, and couples have uterine malformations or the septum, like we discussed earlier, and all of our participants would have seen that image. So all of that needs to be corrected to improve the fertility rate, and just blind injudicious ovarian stimulation is not recommended. So I would suggest 2 or 3 cycles, and I would look for all the other causes of infertility.
Is there a time frame for the treatment on an average, the entire IVF treatment?
So time frame.
Yeah, anybody, or you could just add to your inputs.
Yeah, you just said. Time frame means for, like she said, for ovarian stimulation, 6 cycles. And if you're going to do an IUI, at 3 cycles, you review once and see what is happening. And if you miss something or you have to add on something, you do it at that point. But generally, on an international basis, the statistics show that more than 6 cycles, the pregnancy rate plateaus off and it doesn't increase. So what we recommend is 6 times, but it depends upon the age and and the other factors, the sperm factor and other factors. And you have to, how many IUIs is based on that. Now, regarding IVF, there is no limit to doing IVF. If you can do it and your ovaries are cooperative, your uterus is cooperative, and most important, you should have the I need to achieve a pregnancy. If you have a target like that, and you're all out to get that pregnancy, you can do it as many times. But only thing, every time you have to be careful, assess, go to the best center, make sure that all factors involved in her particular case, they've all been taken care of. And then, of course, most patients are able to achieve pregnancies unless they have major problems, like problems in the uterus and very, very thin endometrium, which is just unresponsive to any type of treatment. Most of them do respond. And today, with the stem cells and the PRP coming into the scenario, a lot of problems which were before unsolved are now solved. And we have given pregnancies to many patients who have failed before, and with multiple failures before they have actually achieved their pregnancies. Those with low ovarian reserve, and even the patients who have a very low sperm count or no sperm count at all. There is a lot of research going on the use of stem cells and platelet-rich plasma even in men. And though we can't declare a huge pregnancy rate, at least 8 to 10% people have achieved pregnancies with in patients who have had no sperms, the use of stem cells, and still very much in the research stage, but there are a few pregnancies which have been achieved.
We go back to one cost-related question, Dr. Parajita. Somebody's writing that the most of the IVF cost approximates that are mentioned are only for the procedure, but the injection hormones are much more costlier, which is not usually conveyed during counseling. Is it so?
No, it actually depends upon the center. We at Prashanth Hospital, we give them an elaborate counseling regarding what all is done, how much cost is spent in the injections. Some hospitals may have certain packages which will not include, but now all of the hospitals give a detailed financial counseling. We give them elaborate counseling of how much will cost for blood tests, for the scans, for the consultations, and for the laboratory charge, injections. And even if we are using extra injections, we will tell them that their profile required additional injections, which is an advanced treatments, everything. We give them very detailed counseling. We, in fact, give them in a printed form, giving them a very transparent counseling regarding the finance, so that the patients are able to take an informed decision with the doctors.
Dr. Lakshmi, what is the role of laparoscopy before IVF?
The role of laparoscopy before IVF may be needed in certain couples, especially when the woman has certain uterine or ovarian problems. Like if you take an example, endometriosis, where there is a lot of blood collections or blood-related issues, which are there in the ovary forming cysts, which we call as endometriosis, which may cause recurrent pain. And this pain can lead on to reduced intercourse for them, frequency of intercourse, pain during periods. And this also leads on to inflammation of the tubes, blockage of the tubes, and this could be a cause of fertility. So they may not conceive with other options, but they may require IVF. So severe endometriosis, the role before IVF is once we reduce the cysts, the inflammation goes down, and the quality of egg which we get during IVF seems to be much better. Evidence suggests that once we do the surgery and we give them certain injections to actually reduce the inflammation, the egg quality which we get is much better, and it is shown that it improves the success rate of the IVF in between. But we also take care that we do not reduce the reserve of the women, so it is meticulously done, this surgery. Similarly, if they have recurrent pregnancy losses, as I said earlier, if there is a correction of these uterine problems, like if there is a septum or is a complete deep septum of the uterus, which is dividing the uterine cavity into two, this can result in a lot of pregnancy losses, which could have otherwise been went ahead good. So we would like to correct all these before placing the embryos. So laparoscopy basically is useful for these kind of women for ovarian problems, uterine problems, and for, as we already mentioned about recurrent pregnancy loss, if there is a weak cervix, the mouth of the uterus being weak, and there was a mid-trimester pregnancy loss, laparoscopy, abdominal cerclage, what we do it through the laparoscopy, we place a cerclage or a stitch around the neck of the womb at a higher level, so that her risk of miscarriage in the mid-pregnancy in the subsequent time becomes less. So this may also be helpful for women.
Dr. Samhita, maybe you could answer this. Like, since IVF involves creating the embryo outside the body, externally, so does it impact the health of the baby in any way? Is an IVF baby any way different from baby who's naturally born in terms of, say, immunity or any other factor, probably?
Certainly not. That's just a very common misconception that a lot of people do believe, but certainly not. And especially at Prashanth, with so much experience at the helm of Dr. Geeta Haripriya, we have so many childbirths, and we have seen a lot of them as adults when they walk in, and all of them are doing absolutely well. So that's just a common misconception and nothing else.
Right. So since we are meeting on the eve of World IVF Day, I would really, because we are also kind of reached our closing time, I would like each one of you to wind up with one myth busted about IVF, or a fact, a solid fact, or a message which you feel needs to be conveyed to people. So maybe we could start with Dr. Geeta.
Yeah, like I described earlier, a poor egg reserve is one of the major issues that we are facing now. So I would recommend that all young girls has premarital, or at least as soon as they get married, they assess their egg reserve, assess their fertility status, and if the egg reserve is low, take treatment as early as possible. And if they're at the age of 30, or if she's still not married, or even at the age of 25, if they are concerned it has happened to a sister, then it's best that they assess their ovarian reserve. And if it is very low, today is the era of egg freezing. So they can all go in for an egg freezing program. So we actually stimulate the ovaries, collect the eggs, and we freeze them. And when they get married, when they find a partner, or when they're ready to have a pregnancy, these eggs can be taken out, because they're as good as an egg which is collected fresh, and we can create babies and create pregnancies as well. So this is a very important thing which I would like them to consider.
Dr. Lakshmi? You have to unmute yourself.
Okay. Am I audible now?
Yes.
Yeah.
So I would like to say that, the fertility as such, as Madam said, there's a declining trend. As such, though India has a young population, the fertility has a definite period. Like women's fertility is highest, I would say, in the mid-20s. It's approximately maybe 25 to 30% per cycle. But as she ages, when she goes to mid-30s, her fertility drops down to almost 15%. And it's even worse beyond the age of 35 or so. So delaying pregnancy, late parenthood, which most of the couple are opting nowadays, can result in later on need for IVF or other such technologies, higher technologies. So, and at the end, when they come to us, the ovarian reserve seems to be very less, so decreasing the chances even further. So it is advisable as such not to delay parenthood, or in case they are thinking of delaying parenthood, there are certain options like freezing of gametes are available, but only for, only if definitely needed. So they have to, consider their pros and cons. They have to know all these effects and then take an informed decision of whether they want to delay the parenthood. Okay, and the social stigmas and the problems and the traditional values, the taboos which is associated with fertility, they have to break and come over, kill all this taboo and start, talking to your specialist. Come for premarital counseling to our fertility specialists. If you have certain, even male people, if they have erection problems, they could talk to us. Get the counseling, the supportive treatments, so that they can work on pregnancy and they can start with their marital life in a smooth way. And so because everywhere information is available, but are you getting it from the right person? Are you getting it from the professionals? Instead of taking it from the internet, why don't you go to a professional and get your proper insights into your problems so that you can, go into a happy married life?
Dr. Parajita.
One final tip for the audience. See, many patients have fear that when we walk into fertility hospital or clinic, they offer only IVF. It is not so. We assess the patient completely, and sometimes patients conceive easily through ovulation induction drugs, simple drugs and scans. When they try naturally, they can conceive. Some people in IUI, and some people, if they undergo simple laparoscopic surgeries, they can achieve the pregnancy easily. And we don't force IVF on anybody until unless it is really necessary. So please don't be scared to come to a fertility specialist and seek proper treatment, because sometimes people delay their treatment and come at the end saying we were very scared because if we step into a fertility hospital, they are only telling us to do IVF. This is not true. So please meet a fertility specialist if you're having difficulty in conceiving. They will assess you and start with the simple steps, what is necessary for you. That's all I wanted to tell them.
Dr. Samita, we conclude with you.
Yes, actually, I was just going through your questions posed by the audience, and there was a very interesting thing that I want to clarify, which a lot of our patients believe in as well, that after achieving a pregnancy through IVF, complete bed rest is mandatory or not. And I really would like to tell them that it is not so. And we at Prashanth do recommend antenatal yoga and physiotherapy to encourage them to have a normal lifestyle even after conceiving through IVF. That is very important. We see that in a lot of mothers. And as far as health and safety is concerned, I would like to conclude that it's very, very important to have the general health checkup for a mother before she embarks on an IVF journey. So as to, and when we see a lot of people in our clinic, and most of them are old, they do not seek treatment effectively in their early 20s. We see them above the age of 35 and 40, and especially they do have a lot of other issues such as they're diabetic or hypertensive and all that. And it's very important for us to identify that earlier on, treat it, optimize it, and then embark on the IVF journey.
Thank you, doctors, for sparing your valuable time and discussing this important topic. And there are a few more questions which you may like to answer them individually, because they're very specific questions where people are talking about their respective cases. And I would like to thank all our audience and listeners who joined in for today's webinar, which was brought to you by Prashanth Hospitals and the Hindu Wellness Series on myths and facts of IVF. Thank you all once again.
Thank you very much.